Tennis and golfer's elbow are common terms that refer to lateral and medial epicondylitis about the elbow, or specifically what we're referring to as tendinitis of our extensor and flexor tendons of our forearm and wrist. It's probably the most common form of tendinitis and overuse syndrome that comes into our elbow office and is often seen with repetitive gripping, lifting, pushing and pulling, and is a very significant and painful syndrome. We do see it in our avid tennis and golfers, but it affects our general population just as much. And so our painters and carpenters, plumbers are quite often affected by this. And even our weekend warriors or someone who's just going out and working in the yard can sometimes develop significant pain and irritation related to tennis and golfer's elbow. In general, when we talk about treatment of tennis and golfer's elbow, I preach patience. This is a tendinitis, an inflammation of the tendons that generally just takes weeks and or months to eventually calm down. And as such, I work diligently with our patients to educate them on appropriate home or even formal therapy regimens that can help them overcome the pain and inflammation in this area. And so we work through stretching exercises, topical anti-inflammatories, which may help decrease the risk of injury to the stomach and kidneys, and blood pressure with oral anti-inflammatories, work on activity modification, very specific strengthening protocols, and even may consider formal therapy to work with dry needling, which is a new technique which has found significant success in decreasing inflammation. In the event that after 6, 12 plus weeks of conservative management, patients are still complaining of significant pain and limitation and inability to sleep and do their activities of daily living, I often recommend patients pursue an MRI at that point because they may have a tear of these structures which are setting themselves up for poor results with conservative treatment. And based on the tear size and other patient characteristics, we may consider the role of different treatment options. And those may include steroid injections, platelet-rich plasma injections, or possibly even surgical repair. One of the things I like to talk about with steroid injections is there's no doubt if we give you one, you'll have great pain relief on the short term, but some of my concerns with steroid injections given around soft tissues is they predispose to breakdown of the soft tissues. Quite often the pain returns and we may often have a worse problem to manage in the future. And so I'm very frugal when I offer steroid injections. I have a long discussion with them about my concerns regarding steroid injections, and at most I'll only consider one with a patient. Platelet-rich plasma injections are when we take platelets and growth factors from your blood and inject them back in along the tendinous edge where the inflammation is originating from. And what this allows us to do is help create an improved milieu and environment in that area, allow for some healing, and there are studies that show on MRI a year later improvement in the connection of the tendon to bone, particularly for our smaller size tears. And so I use this for patients that have maybe a 5 to 30% thickness tear, and over the course of 3 months we'll have a much better opportunity to overcome the pain and inflammation and achieve an excellent outcome. Last but not least, surgical repair. For those that fail conservative treatment or have a much larger tear that I'm more skeptical about the results with all the other conservative management we've discussed, we may consider the role of an incision on the outside part of the elbow, cleaning out the tear, getting it back to healthy tissue, and re-advancing it back up onto bone for a watertight repair. The importance of this surgery is that we protect the repair early on with a splint and then a wrist brace to allow healing of the tendon, followed by progressive range of motion and strengthening. And most of our patients have an excellent result and are able to return back to a full activity by 3 months and a plateau in their improvement by closer to 4 to 6 months postoperatively.